millions of people make health decisions based on information that was never properly proven. I'm a medical doctor, and this channel exists for one reason: to show you what the science actually says. You go for a routine blood test, your doctor calls. Your LDL cholesterol is high. They explain that LDL is bad cholesterol. It builds up in your arteries, causes blockages, leads to heart attacks. They recommend a statin. You fill the prescription. This scenario plays out millions of times every year across America. And here's the problem. Two patients, same LDL number on paper. One has a significantly higher risk of heart disease than the other. Same number, different risk. How is that possible? Because a total LDL cholesterol, the number on your standard blood test, doesn't tell you what type of LDL you have. And the type turns out to matter enormously. I'm a medical doctor. In this video, I'm going to explain what LDL particle size actually means, why your standard cholesterol test may be giving you an incomplete picture, and what tests you should actually be asking your doctor for. First, let's clarify what LDL actually is. LDL stands for low-density lipoprotein. It is not cholesterol itself. It is a transport vehicle. Think of it like a delivery truck. The truck carries cholesterol and triglycerides through your bloodstream to cells that need them for hormone production, cell membrane repair, and dozens of other essential functions. Cholesterol is not inherently dangerous. Your body makes it because it needs it. When your doctor orders a standard lipid panel, the most common cholesterol blood test in America, they measure something called LDL-C. The C stands for cholesterol. LDL-C tells you how much cholesterol is being carried inside all your LDL particles combined. Here is what it does not tell you: how many LDL particles are in your blood and how big or small those particles are. Think of it this way. Imagine you need to move 100 boxes across a highway. You could use one large truck or 5 small trucks. The total cargo is identical. But 5 trucks on the road creates 5 times more opportunities for an accident. LDL particles work the same way. The same total cholesterol load can be carried in a few large particles, or many small ones. And the difference in cardiovascular risk is significant. Scientists have identified that LDL particles exist on a spectrum. At one end, large buoyant particles, sometimes called pattern A. At the other end, small dense particles, called pattern B, and they behave very differently inside your arteries. Small dense LDL particles are dangerous for 3 specific reasons. First, size. They are small enough to penetrate the inner lining of your artery wall, called the endothelium. Large particles cannot get through as easily. Second, stickiness. Small dense LDL binds tightly to arterial tissue called proteoglycans. They get trapped inside the arterial wall. Third, oxidation. Once trapped, small dense LDL is highly susceptible to oxidation. Oxidized LDL triggers an inflammatory response. Your immune cells rush in, engulf the oxidized LDL, and form what are called foam cells. Foam cells are the beginning of arterial plaque. Plaque is the beginning of atherosclerosis. Atherosclerosis leads to heart attacks and strokes. The Framingham Offspring Study, one of the most important cardiovascular studies ever conducted, demonstrated that small dense LDL cholesterol is a significant predictor of atherosclerotic cardiovascular disease risk, independent of traditional lipid measures. Independent, meaning even after accounting for total LDL particle size added additional predictive power. Research from the University of Zurich found that the risk of coronary heart disease is 3 to 7 times higher in people with predominantly small, dense LDL particles compared to those with large buoyant particles, even when total LDL numbers look similar on paper. 3 to 7 times. From a number your standard blood test doesn't even measure. Now here's where it gets more nuanced and more important. Beyond particle size, researchers have identified that the total number of LDL particles in your blood may be an even stronger predictor of cardiovascular risk than either particle size or cholesterol content alone. There are two ways to measure this. The first is LDL-P, LDL particle number, measured through a test called NMR lipoprofile, which uses nuclear magnetic resonance spectroscopy to directly count lipoprotein particles. The second is ApoB, apolipoprotein B. ApoB is a protein that sits on the surface of every single atherogenic lipoprotein particle. Every LDL, every VLDL, every IDL, one particle, one ApoB molecule. Always. This means that measuring ApoB gives you a direct count of the total number of dangerous particles in your blood, not the cholesterol inside them, the particles themselves. A 2025 systematic review published in the Journal of Clinical Lipidology compiled all major discordant studies comparing LDL-C versus ApoB as predictors of cardiovascular disease. ApoB outperformed LDL-C in 9 out of 9 studies. 9 of 9. A November 2025 study of statin-treated patients confirmed that ApoB was a reliable, independent predictor of coronary artery disease, superior to standard lipid biomarkers, including LDL-C. This creates what researchers call discordance, situations where LDL-C and ApoB tell different stories. A 2026 study on familial hypercholesterolemia found that ApoB to LDL-C discordance can significantly misclassify cardiovascular risk when only LDL-C is measured. In plain language, some people with normal LDL-C have dangerously high ApoB. Their risk is being missed entirely. Others with high LDL-C have normal ApoB. They may be being overtreated. And nearly all of them are getting the same advice. Your LDL is high. Here's a statin. Up to 50% of heart attacks occur in people whose standard cholesterol test showed completely normal LDL-C levels. Half of all heart attacks in people whose doctors likely told them their cholesterol was fine. So what causes someone to have predominantly small dense LDL particles rather than large buoyant ones? The answer might surprise you, because it connects directly back to what we covered in video 1. The primary driver of small dense LDL is not dietary fat. It is high triglycerides and insulin resistance. When you eat excess refined carbohydrates and sugar, blood glucose spikes, insulin surges, and your liver responds by producing large amounts of VLDL, very low-density lipoprotein. VLDL is converted in the bloodstream to LDL particles. But when triglycerides are high, these LDL particles become smaller and denser through a process called cholesterol ester transfer. In short, a high carbohydrate diet high in refined sugar directly promotes the formation of small, dense LDL, the dangerous kind. Research published in the Nutrition Journal confirms that replacing saturated fat with polyunsaturated fat, particularly omega-3 fatty acids, is associated with a shift toward larger, less atherogenic LDL particles. And multiple studies show that reducing refined carbohydrates consistently improves LDL particle size and reduces LDL particle number, even when total LDL-C remains unchanged or increases slightly. What consistently improves LDL particle profile? 1. Reduce refined carbohydrates and sugar. This directly lowers triglycerides and shifts LDL toward larger particles. 2. Increase omega-3 fatty acids, fatty fish, flaxseed, walnuts. Strong evidence for particle size improvement. 3. Regular aerobic exercise, consistently associated with larger LDL particle size and lower LDL-P. 4. Weight loss, particularly visceral fat reduction, directly improves insulin sensitivity and LDL particle distribution. Here is the most practical part of this video. Your standard annual blood test measures LDL-C. It does not measure LDL particle size, LDL particle number, or ApoB. These are the questions I want you to write down and take to your next doctor's appointment. Question 1. Can you test my ApoB level? ApoB is a simple immunoassay blood test. It is widely available, inexpensive, and according to a 2026 Precision Medicine Guide from Harvard Health, the single most informative cardiovascular risk marker at the individual patient level. The optimal target? Below 80 milligrams per deciliter for most people, below 70 milligrams per deciliter for high-risk patients. Question 2. Can you order an NMR lipoprofile? This test directly measures LDL particle number and size. It is available at most major US labs including Quest and LabCorp. It costs approximately $100 to $150 and is covered by many insurance plans. Question 3 and 4 follow naturally from those results. Your standard lipid panel is not wrong. LDL-C is still a useful screening tool at the population level, but it is a blunt instrument. For an accurate picture of your personal cardiovascular risk, especially if you have a family history of heart disease, insulin resistance, metabolic syndrome, or high triglycerides, ApoB and LDL particle number are the tests that matter. Before the outro, I want to be precise about something, because nuance matters in medicine. This video is not saying LDL-C is irrelevant. It is not saying statins don't work. And it is absolutely not saying you should stop any medication without speaking to your doctor. LDL-C remains a valid population screening tool. Statins do lower cardiovascular risk in high-risk patients. The evidence for that is substantial. What this video is saying is this: LDL-C alone is an incomplete picture. ApoB and LDL particle number add meaningful information that changes clinical decisions in a significant number of patients. And right now, most patients never get those tests. Not because the tests don't exist, not because they're experimental, but because no one ever told them to ask. If this video changed how you think about your cholesterol results, share it with someone who's been told their LDL is high. They deserve to know the full picture. The next video covers something directly connected to this one. Statins, the world's most prescribed drug. Are they being overprescribed? What does the absolute risk reduction actually look like? And who genuinely benefits? Subscribe so you don't miss it. Drop your questions in the comments. I read everyone. This is medical myth busting. See you in the next one.